this is really pretty important stuff here. And I want to go over this with you and explain how it came about, this research we did. The title is The Realities of the National Influenza Pandemic Response Plan. What's important to realize is that the common cold isn't influenza. Common cold is miserable, you're sick for a while, you get over it. It's just one of nature's other miseries. Influenza it carries a mortality. It's caused by a much different viruses than the common cold. They're from the Orthomyxoviridae family. These are RNA viruses. They mutate all the time because every time they replicate, they make at least one mistake. So when you have influenza, you have the flu, all these viruses are replicating, and they all have different mistakes in it. It's not just this virus you were infected with. You're getting quasi-species of virus, and they're looking for a way out. All they want to do, they're not alive. Viruses aren't alive. It's just a collection of chemicals, and if you put them together in the right order and you put them inside a living cell, it hijacks the cell's machinery, and all it does is make copies of itself. We think they're fundamental, actually, to life on Earth. The most primitive bacteria-like organisms we have, the archaea, have their own viruses. We think this is how genetic information got shuffled back and forth between early species. And we can see this today. There was some talk last night on engineering pigs to harvest their organs for transplants. Well, the big problem with that is they carry a number of proviruses that every now and then pop out of the genome and become viruses. And you definitely don't want one of these if you've just had your heart transplant. So they're clipping these out with the CRISPR-9 system. Anyway, they're very fundamental and they're part of life on Earth. The most common symptoms of influenza is you run a fever. You are really sick. You're miserable. Your entire upper airway is infected. With some strains, the deeper lung tissue is infected. And we have two types of flu. We have the yearly flu that comes around. You have to go get your flu shot. And because it takes 6 months to make a vaccine for the general population, we've got little monitoring stations all over the world, and they try to guess which strain is going to be the one to arrive here. They get it right about half the time. That's the one you get over. Then there's the pandemic strains. And we only get about 3 of these a century. We've had our first one. That was in 2009, the so-called swine flu. We all thought it was going to come out of Asia because 3/4 of the world's populations of pigs and everything are in Asia. Actually, they're in China. It didn't happen. It came out of Mexico, showing we really don't understand a whole lot. So these things can jump out at any time, on the average 3 times a century. Typical incubation period, that is the interval between you actually get the virus in your body and it starts infecting your cells, and the time you show symptoms, it's approximately 2 days. Viral shedding, the amount of virus that an infected person's putting into the environment, that's maximum on the first 2 to 4 days of illness. And children can play a role in transmissions. Number one, they don't control their secretions very well. And number two, they tend to shed more virus over a longer period of time. So in seasonal flu, the little rascals get it at the daycare center and come home and give it to you. So here's the problem. Both the pandemic and the seasonal, you can be infected with a flu virus. It's in your upper airway. You don't have any symptoms. And you're shedding virus into the environment for at least a day. If you look at this blue line on this graph, this is the time in days after infection. And you're shedding live virus into the environment before you start feeling unwell and running a temperature. So you can be in a live market in China with all the birds, and the Asians, they like their food killed immediately. And they'll take it home and cook it. So you've been in these markets, and there's chickens here and there, and they rock, and you take it home. There's a tremendous viral traffic that's going on between all these different animals. This was what happened with the SARS outbreak, okay, the severe acute respiratory syndrome. This came out of a live market. And within a week, it was around the world. So, viral mixing, you're shedding this virus, then you start to show symptoms. The most common way to catch influenza is primarily through the air by coughs or sneezes, and this creates small particle viral aerosols. These are all mixed-sized droplets. The larger particles will go out 3 feet, the Russians believe out to 6 feet, and gravity pulls them to the ground. But there's a small fraction left that are invisible. They're in the 1 to 5 micron mass median diameter size range, and they stay suspended. They're microdroplets. And particles in that size range behave as a gas. They go from an area of high concentration to lower concentration. So they spread out. And what's even more worrying is that these viral particles can stay alive for several hours if they're not in direct sunlight. It can also be transmitted by direct contact with bird droppings, nasal secretions, or through contact with contaminated surfaces. The eyes are a target for some of these influenza viruses. So you're with a patient and they're sneezing and coughing, or you're with your kid, influenza in the coughing, sneezing, microdroplets in the air, and it contacts the epithelia of your cornea. Within 30 minutes, that's going to be in your nasopharynx, and you're infected. This is fairly new sort of studies. Fortunately, these viruses are inactivated by direct sunlight, disinfectants, detergents, alcohol of any type. I don't know if beer works. Well, I'm sure Scotch will. Hand washing reduces the chances of infection. Okay? Aerosol survival of influenza virus in the air. Humidity is very important. And during the Ebola outbreak, I was losing my mind because it looked like they were handling it very primitive in Africa, but they weren't. They were handling it correctly. You want humidity around. You want a tent-like hospital because the virus dies much quicker than in an enclosed, environmentally controlled place like a hospital with a very low humidity. That favors the virus staying alive longer in the air. And these are actual graphs done in chambers. This is under very low humidity, up to 22 hours following coughing and sneezing, and only maybe 1 or 2 hours, maximum 6, under high humidity conditions. So our hospitals themselves are helping, or would help, to keep the virus suspended in the air and viable. This can be critical, both live virus in the aerosol and the low humidity, especially in a high-density healthcare setting like a hospital, and the ability for it to contact the corneal epithelium and cause infection that way. Factors in contact transmission. They did swabs in homes where somebody had influenza and in daycare facilities. And they found live virus in 23 to 59% of objects that they'd swabbed. So you have a loved one at home that's ill and they're in bed, they're contaminating the surfaces around them. Those larger particles fall out and around the thing. These viruses can live for 1 to 2 days on non-porous surfaces like stainless steel, and for 8 to 12 hours on porous surfaces. One of the more deadly influenza strains, the H5N1, and we don't have time to talk about that today, it can survive as long as 6 days on some surfaces. Okay, so 3 things have to happen for the flu virus to be transmitted from one person to another by touching a contaminated surface. 1, a person who's infected must sneeze, cough, or blow their nose, or somehow leave micro droplets of their mucus behind in the air or on surfaces. Next, an uninfected person needs to touch a contaminated surface during the time period that the virus is still alive. You know this, ooh, I dropped the bagel, 3-second rule? That doesn't exist. The minute you touch a contaminated surface, your hand's contaminated. Finally, that person needs to touch their mucous membranes because this has the receptors that the virus needs to get into the cells. So, rubbing your lips, rubbing your eyes, you're infected. Touching a doorknob, an elevator button, you see where this is going. How often do we touch our face? Berkeley University quantified it. They drug some students in, and instead of giving them diesel exhaust, they just put them in a room and let them mill around, and they recorded them, and they counted the number of times they touched their face. An average of 15.7 times an hour. All of them. If you assume that an individual's awake for 16 hours out of the day, they touch their own face at least 250 times a day. One of the transmission factors that is not being addressed by anybody is paper money. We have 2 types. We have paper and we have polymer notes. Okay? England. I went over with my old, 5-pound notes, and they wouldn't take them. They'd gone to polymer. Bloody Brits. Well, they're going to get flu worse than we will. Infectious influenza virus may persist on paper currency for days. How do we know this? I'm glad I wasn't part of this Geneva study. They took purified H3N2 virus and they collected nasal secretions from children. Now, I'm not sure how you do this, but they did it. And they put the virus in the nasal secretions and they put it on banknotes. And they quantified it, how much virus per, so. A strain of the H1N1 virus endured for 10 days on the banknotes. Where do banknotes go? Well, they're, everywhere. And they go in your pocket or your handbag. They're not exposed to direct ultraviolet light. Strain is similar, but not identical to the 2009 pandemic strain, and also to the 1918 pandemic virus, which we'll talk about in a bit. It's possible you could add chemicals. We add fungicides to the US dollar bills. It's possible we could add something that an antiviral agent. In fact, I'm sure we could, but nobody's doing any work on it. The doctor that caught Ebola, the first one, the American, the guy and the girl they brought back, he has no idea how he caught it. He caught it through the currency. Rubbed his eyes. And these notes are really dirty. You know, it's paper. And I mean, if you've ever been to Africa, that used to be a note. I think it still is. But they're passed around and passed around and passed around. So this is an important factor. We mentioned that the eyes are a definite route of infection by aerosol. The H7 avian flus and the 2009 H1N1 strain have an affinity for ocular tissue. In fact, there's documented ocular disease has been reported following infection with all the principal influenza viruses. the nasolacrimal system in the eye, drains to the nasal cavity, and they've done live virus, and within 30 minutes the nasopharynx is infected. So this is really not being ignored in national pandemic planning. If you go back to 1918 and you study these cases, and they're saying, look, we're wearing masks, we're still getting infected. So in a high density healthcare setting, all right, the 1918 influenza pandemic. In March of 1918, an outbreak of a lethal Group A influenza strain occurred in Haskell County in Kansas. Back then, people were living in sod houses. It was very sparsely populated. But Fort Riley, it was World War I, induction. Wilson was getting us involved in the war, and we're trying to raise a 2 million man army. And it broke out at Fort Riley. And it was mild. There were a lot of pneumonia cases, but it appeared to be mild. They didn't stop. I mean, they kept sending people over to France, 10,000 a day. And it started circulating over in Europe during the war, and it came back to America, and it had mutated. And it was violently lethal. This is a normal macaque, rhesus monkey, heart and lungs, nice and pink, would float in water. This is after infection with the 1918 strain. You can see the hemorrhagic destruction, the alveoli are broken down. It's adult respiratory distress syndrome. All the alveoli are filled with fluid. There's no gas exchange occurring. And people were dying in World War I from this. They would turn blue, purple, from cyanosis, the buildup of carbon dioxide, from the time of symptoms to death. And you can find these cases 24 hours. How do we know that the 1918 strain that caused this is dead? Well, they recreated it. They found some tissue slides from the Armed Forces Institute of Pathology, Jeffrey Tonnenberg. And Brevard Mission was an isolated Inuit community back in 1918, and virtually the whole village died. They went up there, and they found one of the bodies in the permafrost that had been frozen with no real temperature changes for 100 years. They exhumed the body, and they got genetic fragments of the virus. They did reverse genetics, and they recreated, that is the actual 1918 influenza strain that caused the pandemic. All right, and by November 18th, the entire United States is in the middle of a lethal influenza epidemic. Within weeks, it infected a quarter of the American population of 103 million at the time, and it killed over 500,000. And you got to remember, 1918 was a lot different than now. Urbanization had just started to reach 50% rural urban. Now it's much, much more. Globally, recent estimates, possibly 100 million people died. Places like India, this virus killed more people than in 25 years of cholera epidemics. In fact, more people were killed in 11 months than during the 4 years of the Black Death, the bubonic plague in Europe. And it joined human history as one of the 3 deadliest plagues ever recorded. In 2014, in spite of spending $120 billion for biological and pandemic preparedness, the United States demonstrated it couldn't handle 11 Ebola virus cases on US soil. This is outrageous. And this prompted us to go back and start like, well, what about influenza? So we started grabbing up the GAO documents, and there's a plethora of these. In fact, you can get them right off the internet. And we started to make a close study of the current 2005, well, it's been updated this year, And both of these, the 2005-2017 National Pandemic Response Plan. And what we found was shocking, and that's the subject of this presentation. For years, scientists and epidemiologists, public health people have been clamoring for what are the blueprints for the United States, how are we going to handle a 1918 type event? And we need stuff like county by county down to the neighborhood by neighborhood, and nothing ever appeared. Government accountability offices scolded the Department of Health and Human Services on 6 separate occasions for failing to develop a national pandemic plan. Then, in 2005, November 1st, President Bush announced the plan was ready. Apparently, the story I have is that he read this book by John Barry, which is a very good book. You can get it off Amazon if you're interested in this type of thing. And he got all alarmed and got a hold of HHS and said, you know, what's our plan? Well, I want a plan. Well, if you're the President of the United States, why didn't HHS go and say, look, we got a problem here? Anyway, irregardless, big fanfare out at the National Institutes of Health in Bethesda, big press conference. We have a plan. It's capable of detecting global outbreaks. We're going to stockpile antiviral drugs. We can rapidly produce new vaccines, and we'll have a ready response at all federal, state, and local levels. The document didn't mince words in its introduction. No other infectious disease threat, whether natural or engineered, possesses the same current threat for causing infection, illness, and deaths so quickly in the United States and worldwide. Now, the plan's rubbish. If you bother to read it, you can get it off the internet. It's fluff. It's just like this organization will do this, and then these guys will do that, and then these guys will do this. And it's why you can't handle 11 Ebola virus cases. Most people in this field found it disturbingly incomplete. And what the plan does essentially is it passes all the difficult problems over to the state and local authorities. All federal governments were going to spend money on it. Irving Redlinger at the Mailman School of Public Health called it the mother of all unfunded mandates. What it did was it made both Department of Homeland Security and Health and Human Services work together to come up with a plan. What they did is they formulated their own plans, and they differ. Continuing coordination failures are likely to make any pandemic situation we get here even worse. For example, Department of Homeland Security plan calls for using antiviral drugs only for treatment. Health and Human Services plan calls for using antivirals for both treatment and prophylaxis. Well, this is an important thing because this year we managed to reach a stockpile of 80 million doses. That was the target. Well, if you're going to use it for both treatment and prophylaxis, you need twice that amount. And there's, 320 million Americans? So it's these type of inconsistencies that cast doubt on the ability of the federal government to function in the coordinated manner that would be necessary to help state and local authorities. Even the New York Times finally managed to get something right in an editorial when they said that the plan looks like a prescription for failure and how poorly prepared the United States was for a pandemic. And then continuing series of GAO reports. You're missing this, you don't have this, how are you going to do this, all the way down. Still going on. In response, a variety of very general, there was this rush of manuals and pamphlets that came out, and they're all fluff. From every government agency you can imagine. Why is the Department of Transportation telling emergency medical services and giving them influenza guidelines for statewide adoption? What's it got to do with Department of Transport? The involvement of the Department of Homeland Security is very troubling. This is a list of their responsibilities. State and community level planning, build a strategic national stockpile, then give it to HHS, CDC to manage. Exercise plans, medical veterinary surge. In reality, the Department of Homeland Security was the major impediment and distraction for any type of successful organized Ebola response back in 2014. They didn't coordinate with anybody. CDC didn't know what they were supposed to do. Nobody did. And their Office of Health Affairs just messed the whole thing up. Projected US and global fatality estimates of a 1918 event occurred today. Health and Human Services estimate that 90 million, or 30% of the population of the United States, will be sick, with a 1.9 million deaths. In reality, this is only a guess. Nobody knows. We've never lived at these population densities in the history of our species before. We are all living in a great biological experiment right now. H5N1 avian strain has a 50% mortality. Oh my God, smallpox only has 40% when it was around. So these are guesstimates. Illness, 90 million, 30% of the population. Patients requiring outpatient medical care, 45 million. Hospitalization, 9,900,000. People requiring intensive care, about 1.5 million. People requiring mechanical ventilation. Oh, by the way, you don't just hook up to the machine. The doctor has to stick the tube down your trachea, and you really have to know what you're doing and how to set the machine, and then it's a lot of nursing for ventilated patients. We're going to need 745,500 of these. Estimated deaths, 1.9 million. Here's our capacity. Hospitalization, we're going to need 9,900,000 beds. We have 946,997 beds total in the United States. ICU care, about 1.5 million people, ICU beds. We have 87,400. Mechanical ventilators, we're going to need 745,500. We have, at the most, we're not even sure, 105,000. There's somewhere between 5,000 and 7,500 in the strategic national stockpile. Deaths, 1.9 million. Mortuary services are really not addressed in the plan. We have about 100,000 undertakers in the United States. We've all been to the funeral homes. They're all about that size. How are you going to handle 1.9 million bodies? So you can see there's problems. For a small average US community hospital, in a 1918-like scenario, you're going to need a 191% increase in your non-ICU beds, 461% increase in your ICU beds, and 198% increase in the number of ventilators you have. In 2017, the national plan was updated. They've added a new intravenously administered antiviral. They spent $400 million helping the company develop it, and it's of the same class as a drug we're going to talk about just now, and it's not going to have any use for the general population. What it's going to have use for is if you're a senior government official. They brought the time for first vaccine manufacturing down to 3 months. Very good. But that's a limited dose. That's just enough for critical infrastructure. No strategic thinking of how to increase medical surge capability, and they're still not addressing the fact you can catch influenza through your eyes. Studies in China have shown that the HEPA high efficiency particulate air mask, the N95 mask, offered only about 75% protection against lab-confirmed influenza. And it didn't matter whether these had been fit tested or not, indicating that the infection probably is occurring either through the eyes or through contact. Now that's going to be virus on the outside of that. If you don't have training on how to take this thing off properly, decontamination training, you're back to, in fact, you've got concentrated virus on the outside of it. And how do you dispose? You can't just throw that thing in the dustbin when you come off the wards. So, it's going all the way down to the janitorial staff and the incinerators and this type of thing. So, we have a condition called biosafety level 4. We use this for things, you've seen the spacesuits on TV, yeah? It's kind of neat to wear those things. But we use these for potentially lethal virus with no drug treatment and no vaccine. Well, what do we have here? We have a lethal agent with no vaccine treatment and no drug treatment. DHS went out and they bought everything under the sun. In 1999, we had this strategic national stockpile in case somebody dropped anthrax on us or nerve agents or whatever. And they created this whole system, and then CDC is supposed to get it to where it's supposed to go. These are push packs that can go out in as little, arrive where they're supposed to be in as little as 12 hours. It's stockpiled by DHS, but managed by the CDC, with support from Air Force and things like this to get it to where it's supposed to go. We mentioned that the amount of influenza vaccine when it finally arrives is going to be limited. This is a plot of what happened in 1918 in England and Wales. There were 3 waves of pandemic. This first one with a bit of pneumonias, then it went overseas, then it came back to the United States. 3 months before the first vaccine, and we're already into the lethal climb of pandemic wave 2. So these first doses are only going to be enough for the US military, for continuity of government. For some reason, that has like several million people attached to it, and state government officials and their selected personnel. Here's the tier system for HHS on who's going to get the vaccine first. The dark red areas are targeted. Of course, it's going to stay at federal government level first, and then it'll spill down. But down here is 123,350,000 Americans that aren't going to get anything. And these are the healthy adults 19 to 64 years old. In the 1918 pandemic, it was precisely this age group that suffered the most fatalities. See this inverse W? We don't see this in normal influenzas. It's usually the very young and the old and infirm that influenza takes away from us. Here, it was the fit soldiers. The virus had adapted to the very age group that were spreading it to become lethal and kill quickly. So, we assume, or the federal government assumes, that there'll be early warning, 2 to 3 weeks. And the WHO have these wonderful graphs, and of course we made it more complicated and subdivided it. But right now we're at pandemic level 3, and a full-blown epidemic is at 5. So we're assuming that there's going to be a warning. In reality, there probably won't be much. You could get on a plane in Kinshasa in the Congo and be at Dulles Airport the next day, 24 hours later. So this isn't all that well taken into account. There's no immediate vaccine. The federal strategy is to stockpile enough antiviral drugs to preserve the continuity of government, federal and then state, and the essential infrastructures of the 120 largest cities. Well, we don't have enough for that. The drug they chose was what's called a neuraminidase inhibitor, Tamiflu and Relenza. Tamiflu you take by tablet, Relenza you snort up your nose. Drug-resistant strains are already out there. So how the drug works, this is the influenza virus, and it has these little suction cups. And what those things do, once the mature virus is made inside the cell, it sticks to the cell membrane and the cell buds and throws it out. So by having this drug in the system, inside the cell, it plugs up the little suction cups and it inhibits the virus from being released from the cells. This enzyme also, on the outer surface, it also helps the virus penetrate the mucus layer to get to the cells of your airway. We stockpiled $1.5 billion of this for the next pandemic. The Cochrane report came out a year or so later, and the top people in England said this stuff isn't even worth taking. It's shortened, if you take it immediately when you start to feel symptoms, it'll shorten your disease course by about a day, half a day to a day. And the first Cochrane report found no evidence that it stopped you from shedding more virus into the environment or that it had any effect at all on hospital admissions or deaths. Then the Lancet published a multi-statistical study saying, well, yeah, it may reduce hospital admissions. The Cochrane reports come back, they had a press conference, they did a new study and saying, nah, look, if I'm gonna give a drug to somebody, if I have to get into multivariate analysis and all this statistical stuff, what good is it? It's probably not gonna work. Yeah? So it's important to note that the next pandemic, we don't know if it's going to be sensitive to this drug or not. We put all our eggs in one basket. Side effects of Tamiflu. Eurosurveillance studies showed that more than half of 85 children in 3 London schools had side effects when it was given as a preventative measure after a classmate was diagnosed. 40% had tummy upset, stomach pain, cramps. 18% reported neuropsychiatric side effects. Well, most kids in grade school, I think, have neuropsychiatric problems. So for actually to report that they had, I mean, there must have been something. They weren't quite listing everything, just that they were behaving strangely. So I don't know. It doesn't matter because it all expired anyway in 2015. The FDA has urgently put out a waiver. And now suddenly they're saying it's a very stable compound. They're testing lots each year to ensure it has efficacy. But you probably won't get more than another 10 years out of the stockpile. The Japanese are smarter than we are. Favipiravir is a designer chemical done by their scientists, and it inhibits the RNA-dependent RNA polymerase of the influenza virus. It doesn't matter what strain. And this is under very evolutionary constraint. Although the virus is making one error every time it replicates, if it makes an error in that polymerase, usually that virus dies. It doesn't get propagated. So very, very clever to pick something under tight evolutionary constraint, a gene like that. There's 3 protein subunits, and design a chemical that'll inhibit that. And because it's inhibiting the viral RNA polymerase, it doesn't do anything. There's no side effects. Your polymerases work differently. So, how have they done with the stockpile? Well, in 2006, Congress gave them another $47 million. This is the Office of Inspector General report. You can call this up on the internet, OIG report 14-129. And they mishandled everything. This large Department of Homeland Security is no better at coordinating things than before. They didn't adequately conduct needs assessment. They just went out and bought everything they could get their hands on. Didn't manage the stockpile. The TSA stock of pandemic PPE, although they're not a part of the national pandemic response, they went out and bought 200,000 respirators. These are now beyond the 5-year guarantee. So the TSA says, well, we'll keep them around for employee confidence. I doubt if they're told that they're out of date. Pallet after pallet of hand sanitizer expired. Why you would purchase expensive hand sanitizer when you could go down, get some hand lotion, some rubbing alcohol, throw them together, you've got the same thing. This is quite good. They can't account for 6,200 courses of Tamiflu. I wonder where those went. All right, surge personnel. We're going to be overwhelmed. We don't have enough doctors. We don't have enough nurses. We don't have enough anything. We have to find a way to supplement hospitals and establish off-site treatment centers. Commission Public Health Service, the National Disaster Medical System, and the Medical Reserve Corps. U.S. Public Health, the Commission Corps teams, 515. These guys are good. They're multidisciplinary staff. They can provide mass care at shelters and casualty collection points. As a uniformed service, they carry rank. They can be quickly militarized. In an emergency, they can surge to 2,000. During Katrina, these guys really were stars. And they came down along with the DMAT teams, and they really did a good job. Part of the surge capability, the majority of it, was due to something called the Inactive Reserve Public Health Commission Corps. The Affordability Care Act in 2010 abolished that from the Public Health Service. Why would this even be in a bill like this? I don't understand. But they got rid of them. And they destroyed that surge capacity. It's gone. Now they are establishing a ready reserve, and the doctors at NIH that haven't seen patients for years, they've been running a laboratory for 20, 30 years. Now suddenly they're going to be required to attend to patients. It's not going to work. They don't even know where to plug the ventilator in. So you had something that was working really well, and then you messed it up. The National Disaster Medical System. Originally, there was more than 9,000 volunteer licensed health and medical personnel organized into 107 response teams. They quit funding it, morale fell, retention fell, and it's really not deployable that much anymore. After Katrina, they changed it all for some reason. You have these DMORT teams. There's 10 teams. How are they going to handle 1.9 million dead? They're not going to be a lot of help. The DMAT teams, as I said, they did really great during Hurricane Katrina. And then they started tearing them apart. We're now down to 55 teams of 75 to 100 personnel each. They're demotivated, they're unfunded. And by the way, they have no strategic plan of their own for dealing with pandemic influenza. They're not trained, and they don't have personal protective equipment. It'll be of no use at all. Yet the federal government's still maintaining to the states that, oh, that's going to be a real help to your surge capability. Well, it's not. The management staffing has been reduced from 144 to 57 people. It got shifted from Health and Human Services to Department of Homeland Security. That wasn't working, so they shifted it back to Health and Human Services. It's a mess. One of the things the stockpile has is these federal medical stations. These are prepackaged. They're flown to an area. They can set up, treat 250 people for 3 days. Unfortunately, local community has to operate them. Federal government just drops them off and helps them. Here's how you set up the beds. And so you have to have a pre-existing, like an auditorium or something like that. We have the Medical Reserve Corps. This is a network, community-based units, medical, non-medical volunteers who contribute to local health initiatives, and they're really good for disasters and things like this. They're founded in 2002 by Health and Human Services to maintain the overall structure, but they've neglected them. There's 936 local units, more than 200,000 volunteers, and they're not training them for anything. It's just gradually withering away. And they're certainly not, they have no personal protective equipment, no training for it, and they're certainly not suitable to respond to any sort of high-risk pandemic duty. In addition, some recent studies, 2005, 2012, would they report during a catastrophe? If it's a natural, and we're talking about any volunteers, they were most willing to report during a snowstorm, mass casualty event, and environmental disaster, less willing to report to an infectious disease outbreak, a radiological event, or a chemical event. Why? Little understanding. They're not properly trained or exercised for these more complicated, and they're worried over personal exposure. So here's a summary of the federal assistance to the states, a summary of the National Federal Pandemic Response Plan. Operating under an incident command system, HHS and DHS are committed to supplying the following: epidemiological tracking and infection guidance. Yes, if they're given the data from the local communities. Federal stockpile distribution of equipment, drugs, and vaccines. Well, we're not going to have any vaccine for 3 months. After that, 123 million Americans aren't going to get it until after the epidemic's over. And we will have only 80 million, maybe 81 million drug doses. We have 325 million people. So that's not too good. Supplying additional federal personnel to assist with medical surge requirements. Now that's not going to work. NDMNS is not pandemic trained or deployable. Most PHS personnel are not ICU and clinically proficient. Medical Reserve Corps is in poor shape. That leaves us the military, NORTHCOM, and the Joint Task Force for Civil Affairs people at Norfolk, Virginia. So HHS has unrealistic expectations for implementing its pandemic plan. It assumes a high pre-existing preparedness at all federal, state, county, and local jurisdictions. In fact, most federal funding is stovepiped to either emergency management or public health, but not to both. They don't talk to each other, they don't exercise together, and one jurisdiction certainly isn't going to share anything with others. So the reality is, the federal government already has a dismal record after Katrina and Ebola. In many regions, the emergency medical services and public health rarely include each other in planning and exercises. There'll be rationing vaccine and antiviral agents. Medical facilities will be overwhelmed. 40% of health workers may be ill at home, either taking care of family, ill themselves, or scared to come to work. Significant shortages of infrastructure personnel, including possibly food distribution. We don't have time to get into that. Disruption of essential community services and existing mortuary services overwhelmed. Again, 123 million of the population at least are going to receive nothing. No vaccine, no drug treatment. So what do? All that's left is what's called non-pharmaceutical interventions. Wash your hands, keep away from other people, don't travel. Some guidelines of how to take care of a loved one that's home ill, and funny little posters. CDC says this early targeted non-pharmaceutical intervention will bring the attack rate down to here. Well, they did the same thing in 1918, and in some cities it had a little bit of an effect, but it was largely ineffective in containing the pandemic. Social interventions, blocking crowds, closing schools, don't get closer than 3 feet to somebody when you're talking with them. Wash your hands all the time. Yeah, that's going to work. Modern metropolitan areas, you got to get to work. You live in the suburbs. You got to take mass transit. Wearing face masks. If you're sick, you put a mask on the person that's sick because it stops this projectile aerosol generation, but it's not going to protect you. We're going to have 91,473,620 infected and seriously ill patients, probably at a minimum. The National Pandemic Plan will ensure that U.S. politicians, military, and essential personnel, the federal, state bureaucracies have first choice for vaccines and antivirals. This will be followed by the healthcare workers and people important, cops, fire, people important for infrastructure. We have no idea, if you're going to use it as a prophylaxis, we have no idea how long you can take Tamiflu. The normal course is for 5 days. Well, that epidemic's going to go on for a couple weeks. You're going to take Tamiflu every day for that length of time? Because you don't know when you're going to be infected. No studies have been done. We really don't know how long the existing things we can keep giving the FDA waivers. Insufficient still, in my opinion, PPE recommendations for healthcare workers. No federal medical surge capability for the state and local authorities outside of VA hospitals, and that's where probably the public health service docs are going to go. No plan for assistance to inner city regions, although traditionally in every pandemic, these have been the highest infection rates and the highest death rates. Well, not all's doom and gloom. Everything hinges on vaccine and antiviral drugs. Scientists have found an antibody now that it doesn't matter what influenza strain you are, it recognizes an epitope of the hemagglutinin protein. We may have a designer vaccine against all strains, it doesn't matter. So they're working really hard on that. We've also, following the Japanese, and we're looking at these RNA polymerase inhibitors. They have one that looks very promising. They're working flat out on. And this is very important. This cute little guy here is a ferret. And this is the best animal model for human influenza. They're really cute. So you take a normal influenza strain, and it stays up in his upper airway, and he gets the sniffles, and they sneeze, and they're kind of miserable, and they get better. If you engineer the 1918 RNA polymerase into it, it's lethal. It penetrates deep into the lung. So by blocking this RNA polymerase with this new drug they're looking at, we may have something really nifty here. And then for vaccine, President Trump hired, instead of fired, a new national coordinating vaccine scientist. This guy looks pretty good. So I have a small team I work with, and I think we could do better with this medical reserve corps. We have distance learning. I'm doing it now for GW, teaching a course. So it doesn't matter where I'm at. It doesn't matter where the student's at. For the special operations community, I got one guy that was on Denali last time, turning in his term paper. So let's train these people up into disaster augmentation responders. Give them a bit like, the practical nurse that takes your blood pressure and temperature. It's sort of that. Teach them how to stay safe. And let's get some equipment for them. This doesn't exist at the moment, but there's an urgent need. If I'm a volunteer, I need to feel that I'm safe, and most importantly, that I'm not going to bring this back to my family. We need something like this. Made in half sizes, and it self-seals. There's a design accordion where it doesn't have to be fit tested, it's going to seal. And you can wear eyeglasses. Then we just have to train you how to decontaminate it, and if you really mess it up somehow, there's ultraviolet light emitting diodes in here that's killing the virus embedded into the filter. We don't have it, I can't find funding. I have a manufacturer ready to prototype it, but the torturous process. Intensive care beds, this is the LSTAT stretcher, life support for trauma and transport, was designed by Northrop Grumman for the Marines who outraced, in the first Gulf War, they outraced all their medical backup. So well, why don't we put an intensive care onto a stretcher? And this thing is, it's for the government to waste money on. But this little thing can attach to any stretcher. It's got a ventilator, drug infusion pumps, cardiac monitor. It's affordable. For the inner city regions, This is called the Expeditionary Provider Kit. It costs $5 million. It can be set up in 4 hours. It's turnkey. It's heated, ventilation, air conditioning, everything with it. Can run for 30 days. Spares, showers, cafeteria, off-site treatment center. Why don't you bring the whole thing in on a train? Highland Park, the middle of Detroit. It's the worst area you can imagine. This thing can drive right in the middle, set up its force provider kit, all the personnel, everything you need is on board the train. You can make these trains as long as you want. It also carries its own ambulances, its own fuel for the ambulances, mechanics. Keep it. I need a train. National Guard, get on the train, bring the train. Alternate care facilities. These don't have to be fancy. I don't like fancy. I like sunlight, humidity. These are all things that inhibit virus. There's the complete train. With the LSTAT stretchers, it's got ICU cars. Finally, DHS and HHS, I think, have had their chance to formulate a national pandemic response, and I believe they've failed miserably. Why don't we make public health service? These are doctors and epidemiologists. DHS are cops. Why do we put cops in charge of an epidemic? If I'm sick, I'm not going to go see a cop. Let's put PHS back in charge of things like it used to be when we had like yellow fever epidemics in Baltimore centuries ago. Build a pandemic response from the local community up and connect it as you go up. Train these medical reserve corps people so they can function as surge personnel and they can do that safely and get them the equipment. And then let's establish exactly what NORTHCOM and the National Guard are going to do. So right now, this could happen at any time. There's a good book, if you like that great influenza. There's another one, but that's really scary. It's called Bird Flu. You can get them off Amazon, but that kind of goes into it. This is what's happening right now. This is 1990. These are all micro outbreaks. This is Mother Nature trying to find a way to get into us and spread. These are human cases. They've died. They carry a huge mortality, but it's not efficiently transmitted from person to person yet. The virus is still trying. How many warnings do we need? This is 1918. This is actually what's been happening over the years. Okay? It's going to happen. Nobody denies it. We need to start getting ready.